Hey everyone, Chris here from MedPrep to Go, and I wanted to tell you about our MedPrep to Go Step 3 review podcast that features over 90 episodes and 40 hours of high-yield content from Dr. Ted O'Connell and Dr. Raj Dasgupta. This is a premium podcast that has already helped over 100 students pass their exam. You can learn more and subscribe at medprep2go.com. Hey everyone, Chris here from MedPrep to Go, and I wanted to ask you to please follow us on social. There may be links in the show notes, or you can find us at MedPrep2Go on Facebook, Instagram, LinkedIn, and now YouTube. We'd greatly appreciate it as we try to spread the word about MedPrep to Go and keep medical education accessible and affordable.
Hi, my name's Alex Conway, and I'm a third-year medical student at Kaiser School of Medicine. Cardiovascular question 13. A 45-year-old man presents to the emergency department for evaluation of a fluttering heart, dizziness, and shortness of breath, which have been constant since yesterday evening. Past medical history is significant for atrial fibrillation and hypertension. Of note, the patient typically takes daily metoprolol, but he was unable to afford his most recent prescription refill. Physical examination is significant for a blood pressure of 90/50, heart rate of 122, and an irregular heartbeat. A normal jugular venous pressure tracing is available online. Which of the following changes to the jugular venous pressure tracing is most expected in this patient? A. Attenuated A wave and X descent. B. Attenuated X descent with prominent V wave. C. Attenuated Y descent only. D. Prominent A wave only. Or E. Prominent A wave with attenuated Y descent. The correct answer is A. Attenuated A wave and X descent. This patient is likely in atrial fibrillation, which attenuates atrial systole and atrial kick, represented by the A wave. Because the right atrium fails to fully empty into the right ventricle, the X descent that typically results from ventricular systole relieving pressure on the right atrium cannot occur. Answer choice B, attenuated X descent with prominent V wave, is incorrect. This JVP waveform occurs with tricuspid regurgitation. The V wave, which occurs towards the end of ventricular systole and maximal atrial filling, is prominent due to the backflow of blood into the right atrium through the tricuspid valve. Answer choice C, attenuated Y descent only, is incorrect. This JVP waveform occurs with cardiac tamponade, which impairs ventricular diastolic filling. Answer choice D, prominent A wave only, is incorrect. This JVP waveform occurs with atrioventricular AV dissociation and is also known as a Cannon A wave. It occurs due to contraction of the right atrium against a closed tricuspid valve. Answer choice E, prominent A wave with attenuated Y descent, is incorrect. This JVP waveform occurs with tricuspid stenosis. The stenotic valve attenuates flow of blood from the right atrium to the right ventricle during ventricular diastole. Key learning point. Jugular venous pressure tracings reflect cardiovascular pathology and are composed of 5 main components: an A wave representing atrial contraction, a C wave representing the beginning of ventricular systole and the bulging enclosure of the tricuspid valve back into the right atrium. The X descent in the JVP is due to atrial relaxation following the summit of the A wave formed by atrial contraction during sinus rhythm. The X descent occurs during ventricular systole with rising RV pressure. The V wave represents maximal atrial filling, and a Y descent represents the beginning of ventricular diastole. Cardiovascular question 14. A 63-year-old man presents to his primary care physician for evaluation of fatigue, shortness of breath while walking, and swelling in his legs, which have gotten worse over the last several months. Past medical history is significant for radiation therapy to the base of the neck 10 years ago for squamous cell carcinoma. Physical examination reveals peripheral edema in the legs, hepatomegaly, and mild ascites. Chest radiograph reveals pericardial calcifications. Which of the following additional features is most likely present in this patient? A. Audible S3 heart sound. B. Biventricular enlargement. C. Kussmaul sign. D. Pericardial knock in early systole. Or E. Proteinuria. The correct answer is C. Kussmaul sign. This patient has constrictive pericarditis, a condition in which granulation tissue formation in the pericardium results in loss of pericardial elasticity, which impairs venous return to the right side of the heart. Pericardial calcifications, seen on this patient's chest X-ray, are usually seen in patients with a history of pericarditis and may be associated with constrictive pericarditis. Signs and symptoms of constrictive pericarditis include dyspnea, fatigue, peripheral edema, and ascites. Kussmaul sign is the paradoxical increase in jugular venous pressure on inspiration due to impaired filling and backup into the venous system. Answer choice A, audible S3 heart sound, is incorrect. This typically reflects fluid overload and enlarged ventricular chambers. It is more frequently associated with patients who have dilated cardiomyopathy and/or severe mitral regurgitation, though it can also be present in athletes and during pregnancy. An S3 heart sound is typically low-pitched, while pericardial knock is typically high-pitched. Answer choice B, biventricular enlargement, is incorrect. Constrictive pericarditis is more likely to cause biatrial enlargement. Answer choice D, pericardial knock in early systole, is incorrect. Although pericardial knock can be heard in constrictive pericarditis, it is an early diastolic sound. Answer choice E, proteinuria, is incorrect. Although proteinuria leading to hypoalbuminemia can cause peripheral edema and ascites, this patient's history of radiation therapy and chest X-ray findings make constrictive pericarditis a more likely cause of his symptoms. Key learning point. Constrictive pericarditis may present with the Kussmaul sign, a paradoxical rise in jugular venous pressure during inspiration due to impaired filling of the right side of the heart.
Do you need a break from studying? Check out the Dr. Raj podcast, where he discusses topics such as wine with Jesse Katz, sarcoidosis with Bob Saget, saving the bees with Sydney S. Sill, and so much more. The podcast also features guest host Becca Spar, who focuses on leadership and connection, as well as Dr. Michelle Kulai and her Everyday Rooms segment, where she talks to patients to share their stories and the challenges that come with different conditions. Just search for the Dr. Raj podcast wherever you're listening now and tune in for a variety of great guests and topics. Hey everyone, Chris here from MedPrep2Go, and I wanted to let you know about our premium Step 2 Bundle podcast, which gets you all of the Step 2 secrets and our Step 2 Questions podcast combined and ad-free. You'll also get early access to all of our Step 2 Questions episodes before they're released public. The bundled podcast is available now, and you can save over 40% with an annual plan. Details at medprep2go.com.
Cardiovascular question 15. A 78-year-old man presents to the emergency department for evaluation of sudden onset squeezing chest pain with radiation to the left shoulder. He has felt this way before on several occasions, but the sensation has never persisted for more than 30 seconds. Past medical history is significant for hypertension. Physical examination reveals diaphoresis and tachycardia, and an electrocardiogram is significant for ST elevation in leads 1, AVL, V5, and V6. Percutaneous coronary intervention is not available, and the next closest hospital is 3 hours away. Which of the following agents is the most appropriate next step in this patient's care? A. Alteplase. B. Bivalirudin. C. Enoxaparin. D. Fondaparinux. Or E. Unfractionated heparin. The correct answer is A. Alteplase. This patient is presenting with an acute ST segment myocardial infarction, STEMI, most likely a lateral infarction. Ideally, he would be treated with percutaneous coronary intervention, PCI, within 90 minutes of first hospital contact, or 120 minutes if transferred to an alternate facility. Because neither of those options is possible, he should receive a fibrinolytic agent such as alteplase. Answer choice B, bivalirudin, is incorrect. Bivalirudin is a direct thrombin inhibitor. It is preferred to heparin for pre-PCI anticoagulation in patients who have a history of heparin-induced immune thrombocytopenia. Answer choice C, enoxaparin, is incorrect. Enoxaparin is a low molecular weight heparin with mostly anti-10A effects. It is used for treatment of deep vein thrombosis and pulmonary embolism, as well as for postoperative DVT prophylaxis. It has a longer duration of action and more complex dosing than unfractionated heparin, and for this reason is not the preferred pre-PCI anticoagulation agent. Answer choice D, fondaparinux, is incorrect. Fondaparinux is a synthetic derivative of low molecular weight heparin with anti-10A activity. It is not preferred for pre-PCI anticoagulation because some data indicates increased risk of catheter thrombi and adverse coronary artery events compared to unfractionated heparin. Answer choice E, unfractionated heparin, is incorrect. Unfractionated heparin is the preferred anticoagulation agent for patients prior to PCI. It is easier to monitor and requires a shorter duration of infusion compared to bivalirudin. Key learning point. Primary percutaneous coronary intervention is the preferred reperfusion strategy for patients with acute ST segment elevation myocardial infarction. When this cannot be performed within 90 minutes of first hospital contact, patients without contraindications should receive fibrinolytic therapy such as alteplase.